encouraging. Okay. You're able to hear me?
Yes, sir.
Okay, I'll start. So, an 82-year-old male patient, unrestrained car driver, had met with an accident while going at 100 kilometers per hour. He was thrown out of the car, and there was a death of a co-passenger. He was brought to the emergency. Okay. On arrival, you note that his heart rate is 130, BP of 80 by 40, respiratory rate is 35, saturation of 86, and GCS of E1, V2, M5. How will you approach this patient? You are in the emergency, and how will you approach this patient?
Sir, he's 80 years old gentleman. He's unrestrained in a car driver. He was in a high speed. So co-driver has death. So I'll go with the ABCD approach, sir. So
Mm.
airway is like his GCS is E1 V2 M5. So which is equal to the 8, sir. So if any GCS less than or equal to 8, so I want to protect the airway by intubating the patient, sir, with the rapid sequence induction.
Okay.
Breathing and ventilation, sir. His saturation is 86% on room air, and his respiratory rate is 35. So he is hypoxic and tachypneic. Initially, I'll provide with oxygen, sir. With face mask, at least 5 to 8 liters per minute.
Mm.
I'll see if there is any improvement with the.
Dr. Shravani, you're
Sir.
already contradicting your statements already. Okay.
Mm.
First, as you said you want to intubate. Then you're telling her you put on a face mask.
Sorry, sir.
Okay. You should be
Uh,
clarity of thought, what you want to do and how will you approach, especially in
okay,
a
yes.
trauma patient. Okay.
Okay, sir. Sorry, sir. After intubating, I'll connect to the mechanical ventilatory support, sir.
Mm.
So for to protect his ventilation also, sir, oxygenation and ventilation. His BP is 80 by 40, sir. He's hypotensive and a heart rate of 130. Hypotension and tachycardia is there. So first I'll secure large bore IV cannula, sir. 2 large bore IV cannula, and I'll give fluid resuscitation, sir. 0.9% of normal saline, 15 to 20 ml per kg. And I'll see if there is any response to the fluid resuscitation, sir.
Okay. You have managed trauma patient.
Yes, sir.
Okay. When they come to the ER, you straight away go ahead with intubation.
No, sir. This
What
is
you
a
do
high.
at the bedside?
Uh, yes, sir. Airway with the C-spine protection, sir. I'll protect the
First is, as
C-spine
you
with.
told correctly, airway cervical spine protection. You, in the meantime, you do a cervical spine protection. You look, airway is impendingly is going to arrest, is patient is going to arrest, or just low GCS is there. You
Yes,
need
sir.
intubation. There's no doubt about that. That doesn't mean that you have to intubate straightforward. You
Okay.
put a face mask in the meantime. You
Mm.
assess. Okay. First, you
Yes, sir.
assess there is obstruction to the airway is there or not.
Okay,
Okay.
sir. Mm.
After that, you make sure that cervical spine protected. Then
Yes.
breathing, you look at the air entry, you look at, you put a saturation probe, you look at the saturation. In the meantime, go for circulation.
And-
Look at the peripheral pulses, whether exhibit is cold or not. Check the BP.
Okay, sir.
Okay.
Mm.
Don't straightforward say that I am going to intubate the patient. That's what you're going to manage, no? Right? In the
Yes, sir.
emergency, when the patient comes, no, you'll do ABCD together almost most of the time. And
Yes.
you'll not say that I just because airway, Jesus, anyway, Jesus, you're going to check at D. You're not going to check in the beginning, right?
Oh, yes, sir.
Okay. If there's
Yes.
obstructed airway, definitely you'll consider intubating first. But
Yes.
in this case, you will preferentially put on a face mask, go and do the other things in the meantime, right?
Yes.
Okay. Can you tell me what is ABCD in trauma?
Sir, A is airway with C-spine protection, sir.
Hmm.
B is breathing with ventilation, sir. C is circulation with hemorrhagic control. And D is disability, sir. And E is exposure or environmental
Okay.
protection, sir.
Yes, very good. Okay. Now, especially in case of polytrauma, so many patients would have come. Okay.
Yes, sir.
In those cases, we do something known as triaging. You are aware of that?
Yes, sir.
Okay. This patient will go into which color coding?
This patient will go to red zone.
Yes. Red. And why?
Sir, he is having like a low GCS, and he is like tachypneic and hypoxic and hypotension with the tachycardia is there, sir. So immediate resuscitation is required for him. So he'll go into the red triad, sir.
Okay. Okay, fine. Uh, you should tell all these factors: speed, thrown out of the car, death of a co-passenger, along with the vitals and severe TBI. Okay.
Okay, sir.
As I discussed with you already, ABCD is very important in this case, and
Yes,
it should involve that it will have a multidisciplinary team. It involves surgeon, it will involve orthopedician, it will involve a neurosurgeon, depending on the case per se, and involve ER physician. It will be involved.
sir.
Okay.
Okay,
So
sir.
after securing the IV access, what will you do?
Sir, initially fluid resuscitation will give, sir.
Yeah. Along with
Uh,
that, you want to do, and especially in this patient.
yes, sir. I'll give injection tranexamic acid 1 gram, sir,
Okay.
over 10 minutes, followed by 1 gram of tranexamic acid in 8 hours, sir, infusion.
Okay.
And
Okay.
like I'll
And
send like when I'm secure on that, like I'll get the sampling, sir, like all coagulation profile, blood grouping and typing, CBC and all. So meanwhile I'll arrange for the blood products also, sir.
yes, very good. Those things are important. Okay.
Mm.
Is there any? Okay, you gave fluids. In the meantime, you gave tranexamic acid. So in the
Yes.
meantime, what you would like to do?
Sir, I'll get one ABG also, sir, to rule out
Okay,
any.
very good. ABG you did. What you would like to do is check in the ABG.
Sir, yeah, like we'll check that lactate, sir, if like which will tell you that inadequate tissue perfusion, like any hypoperfusion or hypotension, or like so we can give the fluid resuscitation by seeing the lactates.
There's one more thing. The ATLS asked you to monitor
Like
along with the lactate.
basics is also, sir. Basics
Yes,
also.
very good.
Mm.
Okay. So you given fluids. You've done base this much. Okay. In the meantime, while you should say, see, if you're examining, if you miss a step, no, then it'll be in a soup.
Okay, sir.
Yeah. So now you examined and you noted that there is a decreased air entry on one side of the chest.
Oh,
Okay.
okay, sir.
So what do you think is the cause?
So decreased air entry in the one side of the chest, it may be related to a tension pneumothorax also, sir, because the patient is having hypotension and decreased air entry.
Oh,
So I will do the immediately fast scan, sir, to rule out any pneumothorax.
okay. Uh, what do you mean by fast?
So this is focused assessment of sonography in trauma, sir. So
Hmm.
which will be placed placed in 4 places.
Hmm.
First is in hepatorenal area, sir. That is Morrison's pouch, and second is like splenorenal area to rule out any fluid collection, and third is like a suprapubic area, like a pouch of Douglas to rule out any fluid collection around the pelvic area, and fourth is like xiphoid process area to rule out any pericardial fluid collection like tamponade or like
There any modification
pericardial
of fast?
deficits. Sir,
Modification of fast you are aware of?
extended, yes, sir, extended EFAS. So where like we can keep bilateral thoracic region probe to rule out any like a pleural effusion also.
Right. So now there is a modification of your ABCDEF in the upcoming ATLS classification.
Yes,
There
sir.
they put X as the beginning. X is for
Yes, sir.
exsanguination.
Yes, sir. Like any catastrophic or critical bleeding, first they'll tell like to give pressure if there is any open injuries, so that first control the bleeding and then like ABCDFs.
Okay. Then one more they have added is further factors which include pediatric or geriatric and pregnancy. You should give due consideration for that. Okay.
Okay. Okay, sir.
Okay. What are the causes of hypertension in trauma?
Sir, in trauma, mostly hypotension is mainly related to the hemorrhagic shock only, sir. Other than that, non-hemorrhagic causes also like tension pneumothorax or like a cardiac tamponade, long bone fractures. These are the causes of hypotension in the traumas.
Okay. 4 and other floor, especially in case of bleeding. Okay.
Yes.
You should include other than that, other than hemorrhage, tension pneumothorax, tamponade, and neurogenic shock also should
Sure.
not come.
Yes.
Okay. This is the X-ray of the patient.
So this X-ray looks like, sir, right side there is no lung markings are absent, sir, and the trachea was deviated to the left side, sir. The lung is collapsed, so which showed like right side pneumothorax.
Okay. It's just pneumothorax.
Because the hypotension is like tension pneumothorax.
Yeah, it's tension pneumothorax. That lung is completely collapsed. There's some
Okay.
medial shift also is there. Okay.
Okay, sir.
How will you manage?
Sir, yeah, initially, like needle decompression, we can do on the fourth or fifth intercostal space, which is anterior to the mid axillary line, sir.
Okay. Then after that?
Then definitely like ICD placement in the fourth or fifth intercostal space only,
Okay.
sir.
So you should always say, see anything like this, you should complete the answer. I'll take it. Maybe uh, the thoracic surgery team opinion of them. You're going to put, but in exam for completion purpose, you should mention that.
Okay, sir.
Okay. So as I told, placement of ICD. And in the meantime, patient was intubated in a flow GCS.
Yes.
Okay. Post
Yes.
ICD insertion, patient was noted to have a high drain output with blood more than 200 ml per hour for more than 4 hours. How will you approach?
Sir, again, I'll start with ABCD, sir. Like airway anyway protected, be oxygen circulate, oxygen and ventilation, like we are connected to the ventilator. Like I'll check for the any drop in the blood pressure, sir. If there is any hypotension, then first I give the blood and blood products, sir.
Okay. How would you like to give blood and blood products?
Sir, as per the like prop trial and prompt trial, sir, which showed like 1:1:1 ratio is which helps in the immediate hemostatic is achieved with that, sir. So I
Okay.
like to give in 1:1:1 ratios.
Okay. What target blood pressure you want to manage in this patient?
Sir, in this polytrauma patient, my target of blood pressure is a systolic blood pressure of 80 to 90 mm of Hg and a map of 50 to 60, sir. I want to maintain like hypotensive, permissive hypotension, which will increases the further bleeding, sir.
Okay. What is damage control resuscitation?
Sir, damage control resuscitation is a permissive hypotension and hemostatic resuscitation with blood and blood products, sir, like mainly massive transfusion protocol and damage control surgery, sir.
Okay. What is the target you want to keep in this patient?
Hemoglobin, sir.
Uh, no, not
Like
map or blood pressure.
sir, map of traumatic brain injury. Sir, a map of 50 to 60 mm of Hg.
This patient also has a traumatic brain injury, right?
Then it is more than 80 mm of Hg.
It's on the higher target. Permissive hypertension, you can't practice at least more than 100 of systolic
Yes,
blood pressure, you will be targeting.
right. Yes.
Okay. So, in the meantime, in this patient, you involved a cardiothoracic surgeon because there's a bleeding ongoing, right? Or a trauma surgeon, depending on the centers. Different centers have a different practice.
Yes.
Okay. In the meantime, you arrange for blood and blood products. You finish the answer always. Okay.
Yes.
You do
Yes.
a trauma surgeon, you involve a radiology opinion, damage control surgery, damage control resuscitation, surgery, need of imaging. What do you feel about the imaging? In this case, are any bleeding patient? You want to take up for surgery or any role of imaging is there in this kind of patients?
Sir, if like the patient is hemodynamically unstable, and fast if it is positive, like I'll go directly to the OT, sir, to uh, not to waste the time.
If it is moribund, definitely you consider. But
Mm,
nowadays, the understanding is if we
CT,
should do a CT
CT
and you
positive.
get a CCT, you'll get
Mm,
better understanding what is the etiology and how to approach rather than going blindly.
okay,
Okay,
sir.
nowadays imaging is recommended.
And then, okay, sir.
What kind of imaging you do in case of polytrauma patients in this context?
Sir, we'll do like CT polytrauma, sir. CT
TB
brain.
polytrauma, no, generally it is not called. It is called something else, whole body CT.
Whole body CT. Like we'll include the CT
In
brain
our
and
hospital,
CT.
they call it CT polytrauma, but generally it is called whole body CT.
Okay, sir.
Okay, indication of whole body CT is a question per se in the exams. Okay.
Sir, like if there is patient who is in shock, where like patient is under influence of alcohol, we are not able to tell the history and also better to do the CT whole body CT, sir.
Hmm. Yes. Okay. What are the major sets of bleeding?
So major sites of bleeding is long pelvic bone
You
fractures.
already spoke. We already spoke about this. It's
Mm.
okay. What is damage control resuscitation? We already discussed about this.
Yes, sir.
Okay, as I told in TBA, systolic blood pressure should be
100.
100 to 120. Okay. What is the lethal trade of trauma?
Sir, coagulopathy, hypothermia, and acidosis, sir.
Okay. What are the hemostatic or transfusion targets in a bleeding patient?
Sir, hemoglobin target is 7 to 8 grams per deciliter, sir.
Okay.
Unless until the patient is not actively bleeding, and PTINR is less than 1.5, sir, and platelet count is more than 50,000, sir. If in traumatic brain injury, it should be more than 1 lakh, sir.
Okay. Yes. Okay. As I told.
Fibrinogen is more than 1 gram per deciliter.
Okay. These are the hemostatic targets. Okay.
Mm.
Patient was taken up for surgery by a CTS team and hemostasis was achieved in that patient with a bleed. I think this also we discussed status of
Yes.
transit in trauma and literature. I think in the exam they don't ask about anything about the evidences. You don't have to worry in IDCCM or ADK exam. In
Okay,
an
sir.
FNP or in DRNB exams, definitely they'll ask. Okay.
Okay, sir.
Okay. The same patient, I was shifted to the ICU now with all this resuscitation and surgery. Secondary survey and whole body CT scan was done, which showed some diffuse axonal injury, but patient disease continued to remain the same with all this thing. Also noted to have a left femur displaced fracture for this patient. How will you
Okay.
manage this patient?
Uh, Sir, again, we'll go for the ABCD approach, sir.
Yes.
This patient, like anyway, airway is protected and breathing is taken care with the ventilation. And hemodynamically, he was stabilized now. And disability, his GCS is low in spite of all this thing because of axonal injuries, sir.
Hmm.
Like we'll take the neurosurgery.
Hmm?
Mm,
See, basically, you have diagnosed with traumatic brain injury because of persisting low GCS.
yes.
The fracture is there. Yeah, you have achieved hemodynamics have stabilized after all the resuscitation and surgery. Right?
Yes, sir.
Okay, my question is there are two issues are there here. One is traumatic brain injury is there.
Femur fracture.
Fracture femur is there. How will
Yes,
you
sir.
manage?
Sir, traumatic brain injury, management is mainly sir, first is like a head and elevation and head to be in the neutral position. Like what are non therapeutic procedures will maintain.
Hmm.
Other than that, the osmolar therapy will give 3% NS to maintain the
Hmm.
uh,
If see finish, see this in the exam, no, especially in EDIC or IDCCM, no.
yes,
If
sir.
if you get a question like TBI, there
Uh,
are six or seven things are there which should come automatically.
yes,
Okay, you can't
yes.
wait to answer that. If it comes to ARDS, generally ARDS will not come as a direct
Like
question. It will be something else. You should be ready to answer it five or six things. Okay,
yes,
TBI,
sir.
what are
Like a
the five
head
or
should
six
be in the
things?
sir.
In TBI management, what are the five or six things you have to tell?
Yes, sir. Like head should be in a neutral position.
Yes,
Avoid
very good.
unnecessarily occlusion of the jugular vein, sir. Head should be in the neutral position. Head and
Very good.
elevation, sir. Avoid hypoxia, hypothermia, and hypothermia, and avoid a hypocapnia or hypocapnia, sir. And osmolar therapy to be given, sir.
Okay. Osmolar therapy, what you would like to use?
3% NS, sir.
Can we use mannitol?
Like studies is most like a favor towards like a 3% NS than compared to the mannitol, sir, because of it will cause acute kidney injury and other problems than
The
compared.
evidences are still fluctuating. I'll say that there is no strong evidence in favor of one. But
Mm.
any specific scenarios where you prefer 3% saline compared to mannitol?
Uh,
Anybody else? Any specific
like
scenario will consider 3% saline compared to mannitol? Yeah, hypertension, AKI. Okay, these are the scenarios we'll consider 3% saline than mannitol. Any condition where we'll consider mannitol than 3% saline?
if there is a rapid increase in the ICP where we can reduce the ICP, like emergently where we are taking for the surgery or like that time, like which help in the reducing the.
Yes, very good. Okay, there's a few scenarios where we might prefer one or the other. Otherwise, both the practice are okay. If you're
uh,
giving osmotherapy, what is the osmolarity target you should keep?
uh, like it should be more than 320, sir.
Yes, very good. Okay. And so you mentioned that avoid hypoxemia, hypercapnia, head and elevation, sedation and analgesia. Sorry, again I mentioned pharmacopia, osmotherapy, nurse-led neuromonitoring. You should always mention nurse-led neuromonitoring in the exam.
Okay, sir.
What are the indications of ICP monitoring?
Sir, if there is any GCS less than 8,
Hmm.
like patient.
Please go ahead. These are all just from the BTF guidelines state. Okay.
Yes, sir.
Sir, if
If there is,
GCS is less than 8 with abnormal CT scan, if GCS is less than 8 with normal CT scan, if A is more than 40, systole it will be less than 90.
Okay. Okay, very good. What are methods of invasive ICP monitoring?
sir, intraventricular, intraparenchymal, subdural, and epidural, sir.
Okay. Which is the gold standard?
Intraventricular is the gold standard.
Yes. Are you aware of any non-invasive techniques of ICP monitoring?
The transcranial Doppler, sir, and optic nerve sheath measurement.
Yes, very good. Okay. So these are the indications as we discussed already. Next. One, sorry. What should be your BP targets in TBI management? Already we touched upon that.
Yes, sir. It should be between one like systolic of 140. Like
According to
that,
BTF,
it will be more than yes, sir. Systolic of more than 100.
it depends on the age also. Okay. Between 50 to 70, it's 100.
Yeah.
Below that and above 70, it is 110. Okay. Can anybody tell me this might be asked in the exam, but not that much. ICP guided therapy versus CPP guided therapy, which one is better?
ICP guided therapies.
Why? In CPP guided therapy, unnecessarily they try to keep a higher BP just to
Yes,
maintain
sir.
the perfusion.
Mm.
Invariably, this patient would have received more fluids and they will have longer ventilator stay compared to ICP guided therapy patients.
Yes.
Okay. So, role of seizure prophylaxis in TBI?
No role of seizure prophylaxis, sir. If this patient is having any seizures, then we can give that anti-epileptic measure, sir.
Any subgroup of patients you would like to use seizure prophylaxis?
If patient is
In severe TBI?
severe
Yeah.
penetrating injuries, yes, sir.
Yes, yes, you should. Okay. Yeah, very good. Next. Role of steroids?
No role of steroids in
Yes,
TVS.
that's okay.
Mm.
Uh, is decompression created to be required for patients who have persistent raised ICP? What is the evidence for that?
Sir, like Initial like DECRA trial and rescue ICP trial, they showed which showed like the mortality benefit is there, but the vegetative state of the patient of more than like 6 months, it is like more in the patients who is having like a decompressive craniotomy.
Okay. Dr. Archana, rescue and ECRA, decimal is for malignant MC in front. Okay.
Okay, sir. Okay.
Okay. So, you are aware of any advanced cerebral monitoring techniques?
No idea, sir.
Okay. It's okay. It may not be asked for your exam. TCD, jugular venous saturation, cerebral microdialysis. These are the it may not, it is not relevant for even your EDIC and MRCP. It's okay. Leave it.
Okay.
The condition of this patient per se, this patient had a hypoxemia on day 5. Patient noted to have a hypoxemia. There were temperature spikes along with a drop in GCS from 8 to 5. Okay. Chest X-ray showed features of ARDS. What are the differentials for this patient? So people can put in a chat box. What do they think their diagnosis also?
Sir, like septic shock, which is causing like hypoxemia and temperature spikes, sir.
What do you mean by septic shock?
Like VAP, sir, ventilator associated pneumonia.
Yes. VAP. Then?
Pulmonary. So pulmonary embolism will also cause hypoxemia and
possibility is there. Then? Go ahead. Anybody? So you should always be attentive throughout the, especially in MRCP and EDIC, you have to attentive throughout the discussion what's happening. Okay. So anybody else? What are the differentials? Okay. In this patient, there's a lot of blood and blood transfusion. It can be background. It can be fat embolism. It can be pneumonia, as you told. It can be stress cardiopathy. It can be paroxysmal sympathetic hyperactivity. Okay. This differential, which do you think is more likely?
Sir, trolley and trolley, like trolley within 6 hours only. So it is more than 4 or 5 days. So it may be related to the stress cardiomyopathy and pneumonia. Sir.
Okay. What do you think about fat embolism?
Like he had femur fracture, sir. So during surgery, there is a chance.
Did they do surgery for the femur fracture?
No, sir, not done.
Did you ask them to do surgery?
Yeah, ask for Arthur.
Did you ask, at least did you stabilize the fracture? Did you put a splint or anything?
Yes, sir, splint was done.
You didn't say that.
Yes, sir.
You didn't put a splint and patient has got it a fat embolism now.
Okay.
Okay, this is a scenario which has come in the exam. I'm not creating a new scenario. For all of you, I'm telling you. It has come in the EDIC exam actually. Okay. It can cause hypoxemia. It can cause cerebral worsening. Patient, I've seen a patient where patient went into brain death because of fat embolism. All these things can happen with a fat embolism. Be careful and make sure that, especially if there's a fracture, you have a differential should be a fat embolism, and you look for pedicare. How will you manage fat embolism? How will you manage this patient person?
Sir, no idea, sir.
What problem is there for this patient?
Like hypoxia and tachypnea is there, sir. Anyway, patient is on ventilatory support. So lung protective ventilation.
Yes. See, now it's a ARDS patient.
Lung protective
You have to tell everything about ARDS again. You don't don't take for granted in the exam. That's what it is more important is don't take for granted. It can present as ARDS. You have to tell how will you manage ARDS. Full list again. The
Okay, sir.
checklist.
Low tidal volume, sir. 4 to 6 ml per kg and a high PEEP, sir.
Then?
Then we'll maintain the pH of between like 7.3 to 7.35, sir, and respiratory plateau pressure less than 30 centimeters of water, sir.
Is there any pH recommendation in ARDS management?
Uh,
Sir, more than 7.15.
See, you don't talk about pH in ARDS management. Why you want to get unnecessarily involved in something with permissive hypercapnia? No, leave it. Now we are talking about proper ARDS management. Just stick to it. What are the ARDS? If somebody asks you how will you manage ARDS, what are the 5-6 things you'll say?
so
Sir,
tidal
PaO2
volume,
between 55 to 80, plateau pressure less than 30, driving pressure less than 15.
Yes, very good.
And
Sedation and
pH,
paralysis.
sir, I have read somewhere that pH should be more than 7.15.
That is permissive hypercapnia. That nobody knows what is the target at this point of time. How much we should target. So I'll say that I'll say that I'll not touch it if somebody asks me how much you tolerate permissive hypercapnia, I'll say that answer.
Okay, sir.
Okay.
Okay. SPO2 target between 88 to 92, sir.
Okay. Anyone have gone through Loco 2 trial? Loco 2. Okay. In this, when they try to use the conservative option therapy, they noted that there are more adverse events were there when they use a conservative oxygen group. There are incidents of increased mesenteric ischemia and all. So till we get a further results, I know still ARDS net says that one. But in the exam, if somebody asks you, especially if they ask you in the context of Loco 2 trial, you mentioned that I'll target a saturation of 92, 96. That is the last trial which has come with the oxygen target in ARDS. Okay, Loco 2 trial.
Thank you, sir.
Okay. So there are certain things you should say. Lung productive ventilation, open lung, IP, whatever, limit plateau pressure, driving pressure less than 15, sedation paralysis, restrictive fluid management. Prone ventilation will not consider in this patient because of TBI and other issues. But most important thing you should do is orthopedic team opinion and
Okay.
stabilize the femur fracture, right?
Okay, sir.
How will you manage fat embolism? By treating the cause. What is the cause?
Femur fractures.
Yeah,
Like
you should stabilize the fracture.
fracture.
Okay. Patient continue to have low GCS with no improvement in the neurological condition. Okay. What you would like to do in this patient?
Sir, we'll repeat the
Yes.
CT brain again and we'll see what is causing further deterioration of neurological conditions.
Very good. Okay, you did a CT brain. It is showing same severe diffuse axonal injury. Whenever there's a low GCS, no, in any
Yes.
it will come in the exam. Patient will have low GCS scenarios. Three things you'll say is imaging, EEG, electrolytes.
Right. Okay, sir.
Okay, always these three answers should be at your fingertips in the exam. Whenever the low GCS is there, these three things should come.
Okay, sir.
Okay. So after this, because what is the age of this patient?
86, sir.
76-year-old. What
Yes.
is GCS?
So, GCS is 8, sir.
Yeah. What is the problem? What is GCS has dropped to 5 after fat embolism?
Yeah, yes, sir.
Okay. So what is the other thing? You have a
Diffuse
axonal injury.
axonal
Yes,
injury.
diffuse axonal injury is there.
Mm.
So what you would like to do in this patient? So always say that I'll take a neurology and see one thing is this patient we might have to offer end of life care.
Yes, sir.
Okay, elderly patient. In exam, generally they learn multiple comorbidities also. Elderly patient with multiple comorbidities, diffuse axonal injury, persisting low GCS. Okay, we'll
Okay,
offer
sir.
end of life care, but always first thing about before offering end of life care is get the facts of the case right. Okay,
Okay.
you should always take the concerned team opinion, neurology and neurosurgery opinion.
Okay.
Take even you alone. You say neurosurgery is also okay. Take
Okay.
neurosurgery opinion. In the meantime, how will you communicate end of life care or comfort care by breaking bad news in these patients?
Sir, first I'll introduce myself to the patient attender and ask the patient attender what he knows till about the patient condition, sir. Because he had a fall, he has come out of the injury, motor traffic accident. So initially he came with a very low, his awakeness is very low when he came, so because of that we has to keep the tube inside the mouth and connect to the ventilator. Because he has multiple fractures and he's having CT scan showed some diffuse damage. So the
Now, okay,
recovery
what
chances.
shall we do a role play? I think it is difficult for you to explain.
Okay, sir.
Okay, I am the son of the patient.
Okay,
Okay,
sir.
and you can go ahead.
I'm Dr. Stravani. So how much you know about the patient condition, sir?
Okay. Doctor, they told me that my father met with an accident. I came. They initially they told that they did one surgery. After that, they told one more surgery. Initially, my father was moving his hands and all. Now he's not moving anything. Nobody is telling me anything. What's happening, doctor? Tell me what's happening. When we can go home with him?
Sir, because of his accident and all, he has diffuse damage to his brain. The condition is improvement from his neurological state is very difficult. Uh, so, uh, like uh,
What, doctor? Very difficult. What do you mean by very difficult? Why, doctor? He was okay when he had come. He was moving his
like
hands.
he had multiple factors which is causing him to be deteriorate in the condition, like multiple fractures he had, and we have placed a chest tube, so many surgeries we has to undergo. So because of his accident, with that, his neurological status is worsened.
You mean because of your surgery, you worsened, doctor?
No, 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 no. The condition which he came here also, it's in a bad situation only he came here. All this, whatever we have tried to correct it, he is not responding to the treatment.
Okay, then what you're telling is whatever you've done till now is waste.
No, sir, it is not that. We have tried all our best to save the patient and to come out of the ventilator and all. So because of his major damage which has happened to his brain, he's not recovering from that. So there is no improvement he's showing from his side in the neurological side.
Okay, doctor. What should I do now? You tell me.
Mainly you can go for end of life care, where the patient will not, the chances of recovering is very less to him now. So you can take comfort care option as of now.
Okay. Okay. What do you mean by comfort care, doctor?
We'll treat him, we'll remove all see, we'll make sure that patient doesn't have any pain during this procedure, where we'll try to remove the ventilator support and everything. So we'll make sure that he'll have adequate nutrition support and not to have any pain during this process.
Okay. What will happen, doctor, after that?
Because he's not not supported by the medications, or ventilator is not supporting him to provide sufficient oxygen. So he eventually his BP drop downs, and like uh, he'll slowly deteriorate further.
You can use the word.
So death with dignity.
Yes, you should say the word.
Okay,
Whatever
sir.
you communicate, if you don't say the word, the people may not realize that he's going to die. They think that he'll be okay with that. Okay.
Okay, sir.
It is the word death. Okay.
Okay.
When will he die, doctor? That means
As soon as, because he is dependent on the ventilator, so as soon as we'll remove that, maybe within hours, he will take. So we make sure that he'll not have any pain during this procedure.
oh, okay, doctor. Then I'll book the thing, crematorium, doctor, for tomorrow.
Uh,
never give a fixed assurances to the family, especially with respect to timeline in
Okay,
end of
sir.
year. Okay.
Okay, sir.
You should say that it's very difficult to say. For
Mm.
few people, it may take few hours, it may take
Mm.
days. Okay, we'll go as it is. Okay, only thing I can assure you is I'll make sure that is with dignity, it doesn't suffer.
Okay, sir.
Okay, you can't
Mm.
assure a timeline to anybody,
Thank you.
especially the
Okay, sir.
context of end of life care.
Okay, sir.
Okay? So you can use Spike's model in the communication. Okay.
Okay.
There are few things are there which might be sometimes they might have a back pain, which they say that there's a fracture, and they might ask what is the role of steroids. Okay. What is the role of steroids in
No,
cervical?
Sir, no role.
No
no
role.
rules.
Okay. The other thing they'll ask is how will you rule out spine injury?
Sir, in a CT polytrauma, we can do the CT spine
So
also, sir.
clinically, how will you rule out cervical spine injury clinically?
Sir, clinically, like if there is any tenderness in the midline, tenderness is there in the cervical spine.
Anybody else? What is that criteria called? What are the criteria which are there?
Sir,
Component.
nexus criteria and Canadian C-spine criteria is
Yes,
there, sir.
please. What are the
Uh,
nexus criteria?
Sir, nexus criteria is if any like a patient should not have any focal neurological deficit, and there is should not have any like a posterior cervical C-spine tenderness, and like a level of consciousness, like it should be alert, and no evidence of intoxication, and there is no distracting long bone injuries. If all these are negative, then there is no radiological evidence is required. Like no, CT is not required
Did
to
you
rule
mention
out.
alcohol?
Sir?
Did you mention alcohol?
Yes, sir. Intoxication.
Oh, fine. Okay. The other question in TBI patient is asked when should we do tracheostomy, early versus late? Okay, you decide regarding that. I'm just telling you a few other points you should know in the exams. Okay, and the other thing they'll ask is brain death. I'll cover brain death in one of the other sessions. That's why I'm not included here. So you
Okay,
can discussion about the brain death, who can perform all those things, they can ask you. Okay. You
Okay,
did very well, Travani. But ATLS initial approach, you were a bit this
yeah,
thing.
sir.
Yeah.
Yeah, sir.
That the if you, that's the you should always do an ATLS. That should be part and parcel of our curriculum. You'll
Yes, sir.
understand better how to manage per se. Or you go
Mm.
to the emergency and manage. I know we are in critical care, it's a short course. But if
Mm.
any trauma comes, so we should go to the emergency and manage. Then only you'll understand the seriousness and how to manage. Okay.
Okay, sir.
You did very well. You know most of the things. Just make sure that you organize your answers.
Yes, sir.
Sometimes, see, if you ask somebody ask you, how will you manage ARDS, give a pneumonia scenario, you'll answer. If
Yeah,
patient
sir.
has a VAP with ARDS, or patient develops fat
Yes.
with ARDS, or
Mm.
patient develops intraabdominal infection with ARDS, or pancreatitis with ARDS, the answer still remains the same.
Yes, sir. Yes, sir.
In the
Yeah.
exam, we'll have a scenario which develops like this.
Okay, sir.
Okay, that time also you should be able to answer. And as I told you for ARDS, how you should know the steps. For TBA also, you should know the steps like this.
Okay, sir.
Okay.
Okay,
Other
sir.
few questions they might ask is massive blood transfusion. What does it mean by massive transfusion?
Sir, massive transfusion is like if you are transfused more than 10 units of PRBC within 24 hours, or like 4 units of transfusion, you have PRBC transfused within 1 hour, or like more than 50% of the blood volume has been replaced within 3 hours, sir.
Okay. Okay. Those people who are especially giving headache, they might ask some concepts like the emergency clamshell thoracotomy, Rebova. You read about Rebova. And some patients might come with CSF leakage following trauma. How will you manage? Then cervical spine injury at a different level, needing ventilation, intubation, and all. And the other thing is perfusion targets in spinal cord injury.
Okay,
These
sir.
3 questions they might ask. And if you go through EDIC, this thing, academy, the module, there is a tier 1, tier 2, tier 3 protocols are there. You can read this
Yeah.
also. Okay.
Yes.
Cardiac arrest with pregnancy, trauma with pregnancy, there's something special consideration nowadays they're giving. There is some difference there. You should understand that. I think most of you know already.
Mm.
Okay, that's it. Thank you. Any more questions? Thank you, everyone.
Thank you, sir.
How did you feel, Dr. Shravani?
No, sir, I didn't do well, sir. I don't know, which I know the answers also, I didn't answer properly.
It's exam, it happens like this only. There will be generally straightforward answers only. Sometimes we get confused.
Yeah, sir. I know airway with the seesaw and protection also, but in I think like I need some more like mm, I need to do more like ASCII station so that I'll do
Yes,
better.
yes. Don't worry. We anyway you are with
No,
us. We'll practice some more sessions.
yes, sir. Yes.
Okay. Okay.
Okay.
Thank you.